would just want to say thank you to Dr. Tarciscio for joining us today. Over the years, we've seen some advances in Latin America, but I've seen someone who's so eager and willing to share knowledge and include others in processes. That is Tato. It's been a joy to see him work in Ecuador, and also to meet friends of his who are also embedded in the work in his native Mexico and in different parts of the region. Tato, there's so much more that I could say, but I don't want to take any more of your time. I just once again thank you, and I could. With all gratitude and admiration for the work that you and others at BGSSC have been leading with the government of Ecuador.
Muchísimas gracias, Rubén. Thank you very much for the kind words and warm welcome. Good afternoon to everyone. I guess, sorry, this first part was supposed to be in Spanish, so I'll switch back to Spanish.
My name is Tato Uribe. I'm a professor in the Global Health and Social Medicine program, and I have been working with the Vice Presidency of Ecuador under the leadership of the ex-Vice President, Dr. Borrego, and his team, who are with us today in this presentation about all of their effort. We have María José García, the current director of the Latin American Corporation for Health. She's going to tell us about that in a moment. We also have one of our champions here, Juan Carlos Alamea, trauma surgery from Cuenca. Thank you. It's a privilege to have this opportunity to work with you.
Jody, sorry, that was not slow.
No. We're going to talk a little bit today about the creation process of the surgery strengthening plan in Ecuador. First of all, I want to say hello to all of our colleagues from Ecuador. It's exciting to learn about everything happening, especially Juan Carlos and everyone. We're very concerned about what's happening in Ecuador, and we ask you to please take good care of yourselves there. One second, please. This is what we're going to cover today in our presentation. We're going to start with a brief summary of how we came to this surgical and obstetric plan. Before we talk about our Ecuadorian plan, I want to clarify that we're going to talk about national plans of surgery and obstetrics and the plan in Ecuador and in other countries. They're not always called the same. They're not always called NSOPs. They have different names, different acronyms in different countries. To introduce, on 29 July of 1980, Dr. Mahler, the director of the World Health Organization, at a meeting in Mexico City, identified surgical care as an essential and elemental part of public health care and described it as the most serious manifestation of inequity in health. 28 years later, in 2008, Paul Farmer and Jim Kim published this article where they referred to surgery as the abandoned stepchild of healthcare. They identified 3 important steps for healthcare. The first is the incorporation of an exclusive element about healthcare. The publication of the Lancet, and third, the 6815 resolution of the WHO. Finally, in 2018, in the meeting on soda care in Dubai. He highlighted that no country can have universal health care unless all people have access to surgery, that it's vital that countries invest in surgical care. The vision is universal access to surgical care and safe surgery and anesthesia care. They identified 5 key messages, six indicators, and the development of a national plan. That's what we're going to talk about today. In that context, the Global Surgery Plan, as a response to incorporating surgical care within national healthcare plans, the plan developed a framework and some set of guidelines to work with different countries to formulate these plans. This manual is available both in English and Spanish, and you can download it in the QR code that you see here. The surgical plan process incorporates multiple approaches and disciplines, finance, governmental processes, in a plan that addresses the needs to develop access to surgical care and integrating access to surgical and anesthesia care within the national healthcare plan. It's important that every point is lined up with the local context of the country. Just like creating strategies against different diseases, the surgical plan is just one component to address a country's healthcare needs. During this process, the governments and their partners have to mold the different aspects within this strategy, ranging from research to finance to supply chains. There are 8 general principles that form part of the national plan, starting with ministerial leadership. This came out of the vice presidency in Ecuador. They need to develop a situational analysis and a baseline study. Then the interested parties have to identify the priorities, and they have to draft and validate the norms. They also have to identify how they're going to monitor and evaluate and follow up. This refers to some proposed plans, but this can vary according to the different national contexts. Those involved can vary. There may be different people involved, including researchers, patients, surgical teams, finance, and even private industry. All of these participants have to participate in developing the plan. Here you can see the progress of national plans. In 2015, the Lancet article was published. Various countries in different parts of the world have committed themselves to developing a national plan. I want to highlight here in Latin America, Ecuador was the first country to develop a national plan. But this was after a lot of countries in Asia and Africa had already developed their plans. You can also see some other important achievements, such as the development of the Pacific region. And hopefully very soon, the Pan American region will have its own manual. To develop these plans, you need information, you need finance, and you need regional plans. Some milestones of the national plan. Every country has to promote this plan. We have learned that there are certain strategies that are helpful to develop a successful plan. You have to have the support and leadership of someone in the government, hopefully in the health ministry. In the case of Ecuador, it was the vice president. You have to have early participation of many different actors. You have to include healthcare indicators in the definition of priorities. Now I'm going to invite to speak María José to talk a little bit about the process in Ecuador specifically. Good afternoon, everyone. It's a pleasure for me to be here with you, sharing one of the most exciting milestones that we've completed. I'm going to start by introducing something that's crucial in the development of any national policy, and that is to establish the background, the context of the country in which you're working. In the case of Ecuador, this directly influenced the way in which we identified and developed the governmental priorities. And this context is going to influence how things develop. Ecuador is located in South America, bordering Colombia and Peru and the Pacific Ocean. The capital is Quito, but the largest city is Guayaquil. This official language is Spanish, but there are many other recognized languages, such as Quechua and a few others. Ecuador is known for its diversity, and this includes very important geographical regions, the Amazonian region, the Andean region, the Pacific coast, and also includes the Galapagos Islands. It's also important to note that Ecuador is divided into several political and administrative regions. There are 24 regions, and they are subdeveloped into parishes, and all of those have a role to play in the national healthcare system. Continue. According to the World Health Organization, we're an upper middle income country. The poverty level is 25.2%. 8.2% of the population lives in extreme poverty, but this distribution between poverty and extreme poverty are distributed throughout different regions. One important indicator is that there's a very high risk of suffering of catastrophic expenditure to cover surgical care or health care. The current Ecuadorian healthcare system is divided by several different, it's composed by several different systems, including the national system is divided into 3 subsystems. There's the public health system, public system, designed to take care of the most vulnerable and low-income population, but also to comply with constitutional requirements to guarantee access to free health care. There is also a social service system developed to protect workers, So people who are employees or who wish to be a part of this system can affiliate themselves. And that system inside of it has 3 systems itself. Including the armed forces services and others. We also have the private healthcare system located primarily in the large cities. In this sense, healthcare services include pre-hospital care, hospital care, and a 4th level of care recently defined as care provided in highly specialized institutions. These are some epidemiological data. The primary rates of death, mortality, and morbidity are presented here. There's something important to take into account that's reflected here. It's important to point out that a lot of the high causes of mortality and morbidity are related to lack of surgical care. And that resulted in really this identification of surgery as a high priority. Referring to the norms that regulate healthcare in Ecuador, SOTA care services are recognized as fundamental within the healthcare system. And there are certain rules established around providing these services, and they are stipulated within the National Development Plan that establishes the priorities around development in the country. There's also a 10-year health plan that was recently launched, and this 10-year plan also establishes its own priorities, including to achieve equity and timely access to care and equitable access to care. And finally, another tool for our normative for these plans is our National Sexual and Reproductive Healthcare Plan in Ecuador. In this context, the national healthcare system has recognized a few priorities that have influenced our NSOAP, and those include maternal and child health, NCDs, and to strengthen primary health care in response to the challenges of climate change. Before I pass on the presentation to Ayla, I want to highlight an important point within the context of the development of the NSOAP in Ecuador, and it has to do with the political moment. During the government of President Lasso, and with the vice presidency of Dr. Borrego, who was invited to lead the development of these plans. He is a surgeon. And following that, Dr. Borrego established a strategic plan, forming a good foundation. That strategic plan had 4 key points, including prevention and attention, around strengthening the healthcare system in Ecuador. With his vision of what we wanted to achieve, together with the health ministry, we started processes to prioritize what things are most urgent to develop
organizados con un énfasis especial por un interés particular del señor vicepresidente en función de su entendimiento de la relevancia de los sistemas.
And given Dr. Borrego's understanding of the importance of surgery, it was established as a priority. I'm going to pass on to Ayla. Hand over the. Good afternoon to everyone. My name is Ayla. I'm studying medicine in Argentina. I'm the coordinator I work with Dr. Tato, and I've worked in the development of the NSOP in Ecuador.
Bueno, so in this part of the presentation, I'll briefly introduce the journey of the National Surgery Strengthening Plan process in Ecuador. In 2021, the Office of the Vice President and the Ministry of Public Health committed to developing the national plan with the support of the Harvard Program in Global Surgery and Social Change. With that, Ecuador, as Tato mentioned previously, Ecuador became the first country in Latin America to lead the process from its government. And our team worked in collaboration with the Ministry of Public Health and the Office of the Vice Presidency of the Republic of Ecuador as technical collaborators to facilitate surgery planning and advance the plan in this country and region. So here is, I'll go through an overall timeline. It all started in October of 2021 when the Vice President met with the PGSSC team at the World Health Summit in Berlin to discuss the development of a national surgery plan for Ecuador. At the picture above, you can see Dr. Barrero, Vice President of Ecuador from 2021 to 2023, with PGSSC Policy and Advocacy Director, both neurosurgeons, and that immediately connected to work together in this cause. So in February of 2022, a collaboration agreement was signed between the Vice Presidency of Ecuador and PGSSC, with multiple meetings being held with the Ministry of Public Health to create an agenda and schedule for the plan. In June, there was a state of emergency due to a national strike, which consequently accelerated the whole process of the creation of this plan. From October to December of 2022, data was collected for the first situation analysis. And in December 1st, the stakeholder meeting was held in Quito, Ecuador. So the main purpose of this stakeholder meeting was to define and establish priorities for developing the plan in Ecuador. Among the main agenda of this meeting was to explain the process of the NSOPs, to discuss the established timelines and clarify the valuable contributions of each key stakeholder, and engage a multilateral discussion on priorities and areas of opportunity in collaboration with local and international groups informing each step of the national plan development. And also review the results of the first situation analysis performed, gathering insights from key stakeholders to inform the analysis outcomes report, identify strategic objective priorities. And later on, Taylor will present in detail the established strategic objectives resulted from this modified Delphi process. So in 2023, we continue with the situation analysis. And in April, the Vice President met with the PGSSC team in Boston, as in the picture above. And in the picture below, this was in September, where among the Pan American Health Organization meeting in DC, the Ecuador successfully organized an event at the Ecuadorian Embassy in Washington, DC, in which the event brought together experts in global surgery, including economists, politicians, surgeons, anesthesiologists, to discuss the national surgical plan for Ecuador, but also how to push this forward to the whole region. And additional, this was conducted as a parallel event to the 75th session of the Regional Committee of the WHO for the Americas, in which the council meets every year, bringing together health ministers, and it was a moment to discuss progress in the health agenda for the region. As I'll show the pictures on the next slide, in this first picture, this is the 75th session of the Regional Committee, and these two pictures on the side are the event that was held on the Ecuador embassy in Washington, D.C. So now going to October and November of 2023 were the final stages of completing the plan. And in November of 2023, the plan was successfully inaugurated. And in the next slide, we have pictures there. It was in Quito, Ecuador, in which we launched the plan in November 13 of 2023. And during, just before I go through this slide, I'll just mention that during the launch event, it was incredible to see how even before the launch, the plan was already having great results and already pushing forward so many successful events in the country. And during the event, the former Ministry of Health, José Ruales, shared important remarks on how this plan already significantly impacted the country even before the launch. So, and it was all based on the situation analysis, which Taylor will be presenting in depth as following. And before I pass to Taylor, I'll just remark again that another important achievement in this process that Dr. Uribe already shared was the development and translation of the plan of the manual into Spanish. And yeah, Dr. Uribe already shared the QR code and the website, but for whoever didn't have time to click, the QR code is there. And now I'll pass on to Taylor. And thank you very much.
Thank you, Ayla. My name is Taylor Wurderman. I'm a surgery resident here in the United States in California, and I am a research fellow here at the Program for Global Surgery. Let me go to my slide. Okay, perfect. So I'll be discussing a little bit about the situation analysis, how that informs the strategic objectives, and in turn, how that helps us analyze progress over time. So the essential questions that we're asking with this is, what are the gaps in access in the country that we're working in? How do we measure progress, and how does that help us inform policy? So we performed a situation analysis tool, essentially is hospital level data, survey data that looks at staffing, equipment, supplies, hospital processes, surgical volume. It's a pretty involved form. Initially, we did an initial round of data collection, looking at just 10 pilot hospitals with the Ministry of Public Health. And then once we validated the survey, we were able to roll it out to 131 total Ministry of Public Health hospitals, which helped inform the stakeholder meeting that was done. And with the data, with this Delphi process at the stakeholder meeting, that's where the strategic objectives for the country were developed. After that, we were able to roll out the form again to all hospitals, so including the MSP hospitals, as well as hospitals with IESS, ISFA, and ISPOL, which are separate health systems within Ecuador. You can see a map here with all the hospitals that filled out the data. An important part of this process was to continuously clean the data, to validate the data. You know, oftentimes we would get data back and the question would be misunderstood, so we'd have to go back and correct some of those issues. And you can see here an example of how the data was cleaned continuously and how we were able to get weekly reports on data as it was being filled out. So essentially, I'll give you a very high-level overview of what was the output of this. The output is quite significant. There's a lot of data, and there's still a lot that needs to be analyzed. But the major things are, the top-level stuff. We were able to generate 4 of the 6 Lancet indicators from the surgical assessment tool. So the first indicator, if you look at the red map here, you can see the percentage of the population that has access to a bellwether facility. Most of the hospitals are in the high population zones. And so most of the country, in fact, out here, there's quite not many people living out here, but about 84% of people have access to a bellwether facility. There are indicator 2, so 26.7 SAO specialists per 100,000, which meets the goal of over 20 SAO specialists per 100,000. But indicator 3, there were 2,388 cases per 100,000 population. The goal set by the Lancet Commission was 5,000 cases per 100,000. And then number 4, the measurement of perioperative mortality. 81.3% of hospitals say that they do report perioperative mortality to the ministry. But with the caveat that 71% note perioperative mortality of 0%. And most hospitals have at least some level of perioperative mortality. So there's some quality issues that have been identified from the surgical assessment tool. So just a brief overview of points that I pulled out that do help us inform policy. Everything that we collect is essentially to ask the question, how do we inform policy to improve outcomes in this country? So, for example, we collect data on the number of beds, the number of ICU beds, the number of functional operating rooms. The key point here is 76.1% of operating rooms are functional, but the inverse of that is 24% are not. So there's 24% of operating rooms in the country that are not currently being used for surgery. And so that's an area where progress can be made to improve outcomes. Quality. We look at the about half of the hospitals report quality, report monthly to the Ministry of Health about quality issues, but about half of them do not. They report annually or longer. The not shown here is the checklist used. 90% of hospitals use a checklist, but 10% do not. 95% of hospitals use pulse oximeters, 5% do not. Those are high numbers, but those are areas where we can identify specifically which hospitals need assistance improving quality. And again, talking about perioperative mortality, identifying the hospitals that do report perioperative mortality and then the ones that do not report it, and figuring out what interventions can be made there. Surgical service delivery. So this figure shows us the average number of specific types of surgeries done per hospital, as well as the type of hospital they are. So we can see the bellwether procedures here, so cesarean sections, laparotomies, and repair of open fractures. So you can see that the especializado hospital, so specialized hospital, are doing proportionally more cesarean sections, whereas specialty hospitals, kind of a little bit more even, but that's where the majority of the repair of open fractures are done. So this helps us understand where resources are needed and maybe where we can invest in other hospitals if there's a low amount of fracture repair being done or other type of surgery. And then equipment and supplies. So this data allows us to look, we ask very specific questions. What type of antibiotics do you have? Do you have the sedation medications? Do you have the anesthesia medications needed? And so the vast majority of hospitals do have access to all of these, but we identified about 13 hospitals that report almost no access to 5 or more of these important anesthesia medications. If they had access to those medications, would they be able to perform more surgical procedures? And so these are all things that the data helps us at least ask and get started in answering and fixing issues. So all of this kind of goes into this idea of the strategic focus and coming up with the objectives that are needed to measure changes over time. So this Delphi meeting was held. It was a 2-day stakeholder meeting. The idea was to identify strategic objectives, activities, and indicators within the 5 domains. The 5 domains were developed at the meeting as infrastructure and equipment, service delivery, surgical workforce, information management, and climate risk. From those domains, a strategic framework was developed, which outlines each of the strategic objectives and the associated activity. And then after that, a monitoring and evaluation plan was developed, which was aligned to those strategic framework. Just so that it's a little bit more clear for everyone, here's a nice idea of exactly what the output from this meeting is. So you have the strategic objective, in this case, ensure the equitable provision of surgical care for all. That's very high level, but how do we do that? What's the activity? The activity is to map surgical capacity and the burden of surgical disease to identify gaps in surgical care. A second objective is ensure that all operating rooms are operational and equipped. So the activity would be ensure the availability of essential medications and surgical supplies. So you can see how this is a very detailed process, and that leads us to the monitoring and evaluation bit. So the process for monitoring and evaluation is to take each activity in the strategic objective, evaluate it for crossover with data that we already collect in the situational analysis tool. And where that crossover exists, we would use that indicator moving forward. Where it doesn't exist, we have to develop a new indicator. So we try to align these as possible, but where not, we develop new indicators. And in total, there were 126 indicators that were identified, with the idea that these indicators will be collected annually at the hospital level. And here's a single example of one of the indicators. So going back to that strategic objective we spoke about, ensuring access and mapping surgical capacity and surgical disease. So we can say the actual indicator would be the total procedures performed per year, aggregated regionally, and overall per 100,000 population mapped by region. These are things that are verifiable indicators that can be collected. There's no ambiguity about that, and it's very important for the monitoring and evaluation process. And I'm going to pass this off to Tato.
Right. Thank you, Taylor. Yeah, so now on to, I'll continue in English just to make this easier to follow, I guess. On the one of the biggest barriers that NSOPs have faced and are around financing and implementation. So to that extent, in this one, we work very closely with the BP office and the Ministry of Public Health, who were in close communication with local communities to identify meaningful implementation projects that are aligned with the population needs and with the National Health and Surgical Plan. As such, these three areas were identified, and they were presented. They're shown here by the abbreviations in purple, and they were presented by Majo before the maternal and child health, NCDs, and climate change. Within each one, there were specific implementation projects, which are shown in this image in blue. And this is not a comprehensive list of all the projects that were identified, but rather it is presented to highlight several local initiatives aimed at strengthening surgical systems, aligned with the plan. These are all ongoing and at different stages. The idea is that all of them would have continued monitoring and evaluation of these projects, as shown in the upper box in red. A priority of the plan is that it is founded on creating tangible, verifiable, and sustainable improvements in surgical care. And this is what this image is trying to encompass as an implementation toolkit. One of the the costing piece is another key piece of the plan. And here we were super fortunate and lucky to work with Dr. Isa, who is the Director of National Health Economy and Sustainability, or System Sustainability. He led a series of weekly working groups and meetings with key stakeholders from 5 of the directed directorates that had some kind of relationship to the costing data that we needed. First, he identified a baseline analysis. From there was some work done to see some optimization and see what would be needed to make the system work better. And from there, what investment needed to be made so that this was satisfied at 100% of the projected demand for the system. And the very interesting piece is that all of this contain an additional, very detailed methodology per each directorate with links to the ministerial agreements and all the robust governance that is already in place in Ecuador to make this stronger. Now, this slide shows some areas that are unique for an NSOP overall. So this is the first time in an NSOP that this is reflected or included. The first one on top it's linked to robust related national policies throughout the whole plan. And this you would see as examples that were shared by Taylor, and in subsequent examples that I will share in the following slide. Second, it includes climate change in the context of El Niño preparedness, and it also has wording of the role of military-civilian partnerships in this context, which is also a unique thing. It also highlights the important role of pediatric populations in the National Surgical Plan, which was something that is not included in all of them. And it includes specific and actionable implementation programs and projects shown in the slide before. And last but not least, with support from NGOs and CSOs working in the space in Ecuador, it includes wording on their role towards realized access to surgical care, which is key here. And here I would like to take the opportunity to thank Carolina Segura and Pancho from Operation Smile and their team, as well as I see Dr. Edgar Rodas from the information shared from Sinterandes, and everybody who has, who helped us and provided feedback on the section of the role of NGOs and SAOs. A key partner in our implementation projects was Dr. Juan Carlos Alamea, with all the work that he has been doing in trauma systems for more than 25 years in Ecuador already. So these are all building on and working with the experts that have been doing this work, and the idea is that they continue to do this work, and we're just helping include their experience in the plan, hoping that it would move forward as it has been doing. And I'll take the example of climate change to cover how this was included. Again, this is the first national plan to include climate change. And it builds on the work of others from our team, such as Rennie, which is a manuscript that you can see here on the slide, and many other works that have been published that are listed here in the slide. This also overlaps significantly with two key policies in Ecuador: their Action Plan for El Niño phenomenon that has been mentioned time and again, and their National Adaptation Plan. And this slide just highlights which sections of the plan mention climate risk or change throughout the plan. You can see it in the introduction, in the strategic focus, in monitoring evaluation, and overall in this process as how it was intended to be covered. And then as an academic organization, we continue to work with the Ministry of Public Health, with local academic partners and champions, many of them here in this talk today, on disseminating this work. Some of it has been published and some of it is still works in progress. And in the same context, we have had the privilege to present this work at international conferences like Bethune, the American College of Surgeons Clinical Congress, and soon in February at the Academic Surgical Congress as well. Of course, this was not a smooth and linear process. There were and still are some challenges and complications. For us at PGSSE, one of them is language, since most of the work that we've done in this space and thus all the resources are in English. But I was very lucky to have two teams of excellent, motivated, bilingual fellows and research collaborators who helped bridge that gap in a seamless way. Another big challenge was the unfortunate ongoing political turmoil in the country, which had implications in our timeline, impact, and potential reach. And as well, financing is always one of the challenges that we're still working on. Despite these challenges, we are positively optimistic on the future, and we're happy to see that, again, this was also already mentioned by Ayla, but Dr. Ruales in the launch of the NSOP mentioned how they had already used some of the information from the situation analysis to enact change and improve access to surgical care in Ecuador in some hospitals. So that was really motivating, that despite or before this being officially launched, it had already had some impact locally. So a summary and next steps, the plan has been launched and submitted to the Ministry of Public Health to follow its due process. We're again optimistic that it will move forward, since the new Ministry of Health is a surgeon, and since several allies, particularly technical champions, remain in office. We will continue to advocate for Ecuador's surgical system strengthening, through these academic publications and the financing of these implementation projects that were mentioned. In the same context, Vice President Borrero and his team made a great progress to include surgical system strengthening in the agenda for this year's PAHO Executive Committee meeting, what was also mentioned by Ayla. We will continue to follow and support these efforts very closely and share them with you guys, of course. And finally, we're very fortunate that former Vice President Borrero, María José, and their team remain committed to this process through the creation of the foundation named the Latin American Health Corporation, which you will hear about next from Majo. So over to you, Majo.
Gracias, Tato. Sí, contarles un poco cuáles son nuestros siguientes pasos como
To talk a little bit about the next steps and what vision do we have towards the future.
que adquirimos con
We are committed,
definitivamente va más allá del periodo de gobierno.
goes beyond one governmental administration process. And now together with Dr. Borrego, we have established a corporation, a Latin American Corporation for Health.
Trazándonos dos objetivos principales.
We have two primary objectives, two horizons, you could say.
Con objetivos locales.
One is local objectives.
Entendiendo que no podemos lograr
The other is understanding that we can't achieve things in our country if similar things are not being achieved in other countries. We need to be one part of a strengthening of surgery on a regional scope. As Tato mentioned and Ayla mentioned, we've already been working within PAHO so that this plan is recognized, promoted as a regional plan, and highlighting what we need to continue with these processes. We have also been working with some specific countries through the good relations that Dr. Borrego developed with his counterparts, not only his surgical counterparts, but also political. And in that sense, we've been speaking with and established relationships with other countries to support and strengthen their public policy strengthening, taking advantage of the lessons we learned in Ecuador. Also in the national plan, and in the national scale, we've taken important steps to reinforce this plan within the country, that it's not negatively affected by the change of government. We're trying to anchor the plan through long-term instruments, long-term public policies, and including the 10-year plan. And we have also taken important steps to secure finance for this public policy. We were able to, at the end of Dr. Borrego's term, we achieved an initial commitment from the World Bank to help finance the plan in the next year. Definitively, in every sense, a change of government can mean a huge risk. It's a challenge, but we have strong expectations to be able to continue forward so that it becomes a solid public policy, validated, and it can be implemented. Because of the relationships that we've established with the new health ministry, and as we said, we have made sure to include a lot of sustainable elements within the plan. Also, we've been able to develop some specific plans in the country that respond to specific local realities, including gathering information, we've been able to keep a team permanently based in the different territories. As you saw the national maps, there's a concentration of healthcare services in the high population areas.
en ciertas poblaciones que en otras, no por su
but less populations have less
y ha sido
access.
precisamente en esos lugares en donde hemos tratado
So in
de
those
hacer,
areas of less access,
levantamientos de información más
we've been
inmersivos,
working
y esto nos ha
to have
facilitado
gather
el
more
poder desarrollar
information,
estos proyectos,
and we've been working to identify
con los datos que
and
podemos
complement
presentar
specific
y identificamos tres
strategies.
proyectos principales.
And we were able to
Uno es,
identify 3 primary projects.
abordar la problemática, los altos indicadores de mortalidad y morbilidad materno-infantil en la zona.
One is we identified high levels of maternal and infant mortality in the Amazonian region. We want to improve the infrastructure and installations
con pertinencia cultural adaptados a su cosmovisión.
of healthcare facilities that are adapted to the local culture.
De trauma de las Islas Galápagos debido a
We also need to work
la
on
cantidad
the
de recursos
trauma
que necesita esta
installations in the Galapagos Islands
los casos
to be able to
que
address the
con más
needs
frecuencia se ven que son de trauma.
of high trauma cases that occur there,
Buena resolutividad en las islas.
because there's no good services there.
Trasladados al continente
Those patients have to be
vía aérea. No todos logran
transferred by air
y si
to the continent, and that's not always possible.
hacerlo, muchos son pagados por la persona.
A lot of times people have to pay very high amounts to be transferred from the islands to the continent. So we need to improve trauma services in the Galapagos Islands. We also identified that one of the primary causes of death for women in Ecuador is cervical cancer. That has also been another focus. So those are the 3 high priority projects that are going to be within the 10-year plan. And these have already been adopted by the healthcare ministry. And so we're working to guarantee continued attention.
Este objetivo que nos hemos trazado. A futuro lo que procuramos
In the future, we are hoping to
el financiamiento que nos permita
secure enough finance to continue implementing these projects, but at the same time, building networks of collaboration in the regions to continue to support other countries in Latin America to together work towards our shared goals.
Muchísimas gracias, María.
Thank you, María José, Tato.
Voy a revisar aquí bien los nombres para no pronunciarlo mal. Doctora Rangel.
Dr. Rangel, thank you to all of you. I'm going to share in one moment. Thank you again to everyone.
Voy a compartir mientras ya estamos un poquito pasados de la hora y pues no.
We're a little over the time, but I want to share.
De ninguno, pero obviamente me imagino que hay muchísimos que tienen más.
But I imagine a lot of people probably have questions for the entire team. For those who can stay,
un rato más.
We could stay a little longer.
No sé si tal vez Natalie me puedes ayudar a dejar compartir.
Natalie, would you be able to help me share screen? I'm going to share the biographies of the different speakers. For those who weren't able to enter from the start, I want to make sure that this information is in the recording of this presentation. So here I'm going to leave this while we address a few questions so that you can look up these people later if you would like to contact any of these people. Does anyone have any questions for any of the speakers?
Doctora Viasola.
I have a couple of questions.
Creo que la doctora Viasola, no sé, Richard, si quieres comenzar tú o la doctora Viasola que tenían la mano levantada. Richard, sorry, I don't know if would you like to start, or I think Dr. Viasola has her hand up.
I will always defer to my presidente.
I
of
knew it.
G4.
Dr.
Yeah.
Biasol. Go ahead.
Thank you very much for this and very enlightening presentation on the first national plan and NSOPs for Ecuador. It's enlightening, it's interesting, and it seems that the SAO density for Ecuador is actually more than the minimum that is requested. That is 20 per 100,000 population. You have 26.7 SAOs per 100,000 population. I must tell you that this is much more, probably 10 times more than Nigeria. I'm Nigerian, and our population in Nigeria is over 200 million. You know, so so that is quite interesting. Now, among this population SAO, what is your percentage or the density of anesthesiologists or anesthesia providers, specialist and anesthesia provider? That's one question. And what is your target for your SAO density in 10 years? Because I see your plan is for 10 years. So what are you looking at? Going from 26.7 to what? Those are my questions.
Yeah, so I think we can answer it together. So I don't know off the top of my head the anesthesia numbers, but there were a relatively equal amount of anesthesiologists, surgeons, obstetricians. So it wasn't like a stark difference. There weren't a significantly low number. As far as the SAO numbers, they do meet the goal, which I think was surprising for everyone as we ran the analysis. But further down the line, we're still doing more analysis. There are regional gaps in SAO numbers, and I think that's kind of where all of this is moving towards. It, you know, we look at a single country number, it doesn't really tell us much, but the regional numbers actually tell us information, and they give us areas where we can intervene. And so there are those urban-rural divide, but then also there are urban divides where there's places with higher population but not as many hospitals, or higher population but not as many surgeons or anesthesiologists or obstetricians. And then that you further kind of expand that to where do children have access to pediatric surgeons or a pediatric hospital? So there's quite a few ways that you can take this, and we're working towards that. So I don't think we haven't set a goal because the goal was met, but I think the goal is that each of the regions does have the 20 per 100,000. I think that would be the goal. Correct me if anyone else has any other thoughts on that.
Thank you, Richard.
My first question was, you had mentioned that your measures of success, the survey that you did, which is the baseline, every year you're going to update that? Is that the plan? And it's going to be done by each hospital, or is that going to be the responsibility of the ministry as this information is delivered to the ministry from each hospital? Who's going to be responsible?
I can answer that and as well. So the hope, the plan is that it is a annual survey done with a few additional indicators that haven't been added to the survey yet. And those essentially would be a survey that the hospital fills out. It is a lot of information, but it's information that most hospitals are already collecting. The process has to be validated through the ministry and through the department of, or what is it, the Ministry of Statistics? I forgot what the name of it is. And so that is the hope. It's not at that point yet where we can say for sure that it will be run by the ministry, but the individuals at the hospitals will fill it out. It would be an obligation if everything works the way we hope it works.
Okay,
yeah,
because that'll be important.
Yes.
Who will be responsible?
Yes.
And who's delegating it? Will it come from the director of the hospitals, each individually? Will it come from the Ministry of Health? And does it require any additional financing? All things that could complicate it. The second question I had was related to, there seemed to be a large expenditure that's going to be required for these hospitals to reach the desired targets that you have set. Has that funding been identified? Is that a commitment of the government, of the ministry? I'm not.
I think I can respond to that question and also add a little bit regarding the previous question. For the health ministry, it was a very valuable experience to receive all the information that was gathered to build the policy. This helped the ministry have information that the hospitals were collecting, but that information was not reaching the decision makers, including the health ministry. I think the way that it was implemented taught some valuable lessons about how to gather this information in a timely and simple manner and to permanently establish this. But there is not yet a specific commitment by the ministry. It's one of the topics that we need to address with the new authorities in the health ministry to assure the sustainability of the plan. So finding that finance and that commitment is still pending. Regarding the commitment of the health ministry towards finance, the ministry did commit itself to finance it. And as Ayla mentioned, there was already, during the construction of the plan, there was a demonstration of this commitment in the budget, even while they were still building the plan. They were committing, put $26.7 million in equipping, 98.9 million in building and training, developing human talent. They contracted about 6,600 more staff. So they committed a lot of millions of dollars. The commitment to continue these investments is strong. Nevertheless, we have to renew this commitment with the new authorities. And although we understand that the resources there are never enough, we have approached the World Bank to provide some backup to our plan, to support this plan. So we can really operationalize the plan this year. And this project for the country and the support from the World Bank is contemplated. Thank you, Maria Jose.
Okay. There are a lot of other hands up, so I won't ask any more questions until the others have had an opportunity.
Yeah, the other Richard has his hand up.
Thanks, Carolina. Thank you so much for a wonderful presentation. Great to hear the work that you're doing. I know SAO density is often used to look at workforce, but one of the pieces that I know International Council of Nursing has talked about is the fact that we're going to have a huge shortage of nurses. And I'm wondering if you've looked at the nursing workforce in terms of how your plans will include the nursing workforce and distributing that with rural, urban, and trying to increase the nursing workforce also as you work on your national surgical plan.
I can speak briefly to that. That data is, we have that data. It's not presented and it hasn't been collated yet. But we were thinking about that and how the nursing, the technical, like the surgical techs, the equipment people, how they're involved in all of this process. And so that's additional data that we have, and that just needs to be put together. It was not explicitly put into the plan though. Yeah.
Thank you.
Thank you. Ruben?
Carolina, I just want to say thanks for flashing the bios, because I think it's important to acknowledge the depth of expertise of the individuals who took the time to present today. And yet, I try to introduce Tata thinking that we might have an opportunity to highlight each one of them, but I do love the fact that they went one after the other, and as they talked, they introduced each other as Taylor, Majo, Ayla, and you can see the quality of the friendships that are developed as you work together. I just want to acknowledge that. Thank you for that. It's a wonderful example. So Ecuador sets many firsts, right? First country, probably the first one to include climate change, the effects of climate, really emphasis on also the pediatrics. It's got the relationship with the military. Is the first one to actually invest while using the data being collected by the National Surgical Plan. Many firsts you ought to be proud of. And yet when we see all the other national surgical plans, we always are stuck with the financing after the National Surgical Plan. And in this case, you made great headway working together, and the government's leadership and engagement was fantastic. And certainly you as an academic institution engaged in humanitarian assistance civil society, fantastic. But in this setting, maybe Majo, if you wouldn't mind me directing this question to you, if you had 3 or 4 more years in the vice presidency of the country, in addition to the World Bank and the usual national fiscal options, what would have been other outlets for financing of a national health vision, such as the one you all set in motion?
When we started this process, when we started to build and to call the primary actors, among them were the authorities representing all the subsystems of the healthcare system, all of those related to the public healthcare system. We had a meeting to develop a commitment. We explained to everyone what were the final objectives, what do we need as commitments from each of the institutions. In that sense, we achieved from the finance ministry and from the representatives of all of the institutions, including the healthcare system, included finance for the plan. And we needed these commitments before we could approach other sources of funding to show that there was co-responsibility to address the needs with each institution's own funds. So beyond the budget of the public health ministry, which is already mobilizing, we had the commitment to mobilize resources from all these other subsystems to collaborate in all these aspects of improvement of healthcare provision in the country.
Thank you. Richard? Richard Moser, do you have your hand up? Do you have a question?
Back to Richard again.
Hello.
Yes.
I do have one more question. Dr. Barrero, as the vice president and as a surgeon, a neurosurgeon specifically, has been such a driving force in this incredible program. And he has created this foundation. And I presume the foundation is going to keep the pressure on the Ministry of Health to realize this. But has this ENSO been inserted into the secretariat, the bureaucracy of the ministry? Has a person or a department or an office been assigned the responsibility for achieving these goals? Is it now firmly implanted within the ministry?
With the launch in November, together with the Public Health Ministry, the policy or the plan was handed over to the health minister and to the working group that was built within the health ministry, because the plan connects many different actors within the health ministry. It implies work by many of them. And right now, there's still one process that's pending, and that's within the public health ministry. They have to include a policy within the national, published within the national registry. They have to fulfill certain standards within the ministry. We have been studying this, and we know that the plan complies with all the requirements, but we are pressuring the health ministry to make sure that they are aware that we presented this, that it's been launched, that its implementation is their responsibility, but still pending is this formal validation process. In that sense, the implementation will be shared among all of these collaborating teams. I wanted to add a comment that for those of us who work in Latin America, this work is an example from the point of view of researchers and implementation. The work that we have done approaching different governments in which Operation Smile works, it has been difficult to develop a SOTA plan. A lot of countries have their own, they develop their governmental healthcare plan or development plan. So a lot of governments and ministries, they want to stick with, they follow these guidelines that are already established. So Ecuador gives us a really good example of how to develop a specific surgical plan and how to link it and how to make sure it's implemented within changing administrations. We know that Latin America is like that. There's always governmental turnover. It's a challenge. It has been a challenge in different countries to have a specific surgical plans. The objectives and priorities in different countries in development are often focused on child mortality. And congratulations for this work that you've done. You can count on our support. We are hoping to be able to replicate this experience in other countries. Bibi, you have a question?
No, iba a decir algo similar a lo que tú habías dicho, Carolina, por eso la volví a bajar.
I was going to say something similar to what Carolina said.
Una de las cosas que creo que es importante.
One thing that's important,
cómo hacer esa transferencia a nuevos
how do we transfer these plans to new administrations when there's government turnover? How do we make sure that new governments continue to advance based on all the work that's been done?
cómo hacer para
Based on our
hacer
experience
políticas
here in
públicas
Colombia,
en
one
esas
way to
iniciativas
achieve
de
that,
los gobiernos. Entonces, sí, era algo similar a lo que tú estabas diciendo, Carolina.
so it's similar, just wanted to say something similar to what Carolina was saying. Thank you.
¿Tiene alguna otra pregunta? No veo acá en el chat más manitos
I don't see
levantadas.
anyone else.
Carolina, yo quisiera nada más hacer un comentario sobre
I just want to add a comment on what you said.
y es que para Ecuador no fue diferente.
For Ecuador, it wasn't
Ya
different.
nosotros cuando llegamos,
When
cuando
we,
el vicepresidente Borrero llegó al gobierno,
when the Vice President Borrego started in this government and took on this challenge,
ya había muchos planes.
there already were many previous established plans.
Incluso el ministerio tenía
In fact, the health ministry had a normative agenda, very established, and it was very difficult to open space to generate this new policy. One of the primary issues was the conviction that came from the highest level of government. That was very important. This relevance that was established from the highest level of government was key. The work that was done by Dr. Borrego, the way they advocated to explain why it was important to include this policy promoted from the Vice President's office. As Dr. Bisola mentioned, the fact of having a neurosurgeon in a political position of such a high level was fundamental to be able to advance and achieve what we did. And the head of the new health ministry is also a surgeon. And therefore they understand the importance, the relevance of the work that's been done. And they recognize the social impact that this is going to have on the country. They need to fall in love as we are with this plan. Thank you very much, María José. One final question.
A nivel de las multilaterales, en el WHO el año pasado se aprobó la resolución 76.2 de atención de emergencia, de cuidado crítico y cuidados operatorios. Ha habido ciertos debates, mi opinión es que puede haber una simbiosis, pero ha habido ciertos debates y temor de que el enfoque en 76.2 dé al traste como el enfoque de 68.15 y que los planes quirúrgicos que han sido un trabajo tan arduo por tantos años, de repente quizás ya no sean prioridades para otros gobiernos porque ahora hay una resolución un poco más novedosa. No sé si han abordado este tema, porque si estamos pensando en utilizar a Ecuador como un ejemplo, que debe serlo, en cuanto a esta materia de política de salud, hay una forma ven ustedes quizás una forma de unificar las tendencias o la visión de una resolución con la otra, o sienten que el mismo temor que algunas personas han expresado en otro continente, de que 76.2 quizás le resta énfasis a 68.15 y a nuestros esfuerzos en planes nacionales quirúrgicos. So, Georgia, so in the last World Health Assembly, Resolution 76.2 was approved of emergency critical and operative care. And whereas many of us saw this as a symbiotic process, I believe, and certainly personally, I thought many others were really concerned that this new resolution on emergency critical and operative care will do away with the goodness of 68.15 and the efforts, such as this one, that have followed 68.15. Have you discussed that moving forward as part of the strategy towards this vision, or I don't know, is there an agreement or disagreement with the posture that people in other continents have potentially have that share that fear of de-emphasizing 68.15?
Tato, creo que ustedes quieren responder.
Thank you very much, Ruben, for that question. I can speak a little bit to that, and I let others pitch in. And I think I'll do it in English first and then in Spanish, since Judy has left. But so agreed. We have had this conversation. I don't know if we had it at the NSOP level or at the, at the, not even at the PAJO level. We've had it internally. And one thing that we're trying to do so that is not the case, I guess, is to, in our academic publications, reference both as if they were complementary and building on each other, and maybe adding some, in parentheses, or when we cite, the latest resolution, kind of add in parentheses after operative parentheses surgical care, or vice versa, to make a allusion that this is all building towards the same goal, and we are, this is pushing the needle forward and not going to hinder the movement in the future. So I guess that is one thing that we're trying to do academically, and we hope that once this is discussed in the executive meeting of the PAJO, that would be again an opportunity to kind of blend the language a little bit further, so that it is towards a stronger surgical system strengthening wording and not the latter, I guess. And I can translate that or I can speak to that in Spanish briefly. Pero muchas gracias por la pregunta. Y sí, bueno, no es algo que discutimos a nivel del plan de fortalecimiento quirúrgico nacional del Ecuador. Sin embargo, es algo que hemos discutido internamente, y la manera en que lo vemos, o lo que estamos tratando de hacer, es incluir en las publicaciones académicas, citar las dos, ¿no? Las 6815 y las 76.2, como si fueran, como si estuvieran... sí, se me fue la palabra, perdón, voy a Spanglish otra vez, apoyando, que estuvieran elaborando la una en la otra, y que estuvieran hablando de lo mismo o creando hacia lo mismo, y en algunas ocasiones igual incluir en paréntesis, cuando hablan de operativo, incluir quirúrgico o algo así, para que la gente como que hacer la transición un poquito más menos controversial y más simbiótica, si se pudiera hacer de alguna manera, disminuir un poco ese discurso que existe y que nos preocupa a todos, sin duda. Y ojalá eso lo podamos manifestar de una manera más clara en el futuro, en la reunión del comité ejecutivo de la PAJO.
Muchas gracias, Tato. Dr. Biasola?
Yeah, I just want to say that the two of them, yes, they are different, but they complement, because NSOP is planning, it's futuristic, and, the policy is very, very high level, but EcoCare really is operational, is at the grassroots, it's hands-on, it's what do you do in the hospital or in the clinic, how do you deliver care hands-on at the moment? You don't wait for the future when it comes to ECHO. It's emergency care. What do you do? How do you save the patient at that particular moment? It's critical care. How do you prolong life? How do you buy time? It's operative care. What do you do? How do you intervene? So it's interventional, and it's calling us to think right now, to intervene, to do something, not to sit down and just plan. So it's right now, right time, as well as looking at the NSOP plan. The WHA 6815 has a plan to take you from point A to Z, or wherever we want to go to, what is going on right now, and ensuring that we make the changes and the development and the investment towards where our goals. So that is the difference between the two. They work together. We cannot ignore one for the other. Both of them must be implemented, together. So that's the difference. And it takes away the name surgery, but that doesn't mean that surgery is not important, or obstetrics is not important, or anesthesia is not important, you know, because you have all these people involved in echo care. So that's the difference between the two.
Thank you very much, Dr. Biasola. Muchísimas gracias, Dr. Biasola. No veo ninguna manita más levantada. I don't see any more hands. So thank you so much to all the speakers. We're half an hour past, so I really don't want to steal more of your time. Thank you so much. Muchísimas gracias a todos por su participación. It was a great presentation. Please, you know that you have friends here, that we're here to support you and to learn from the work that you do, and you know, we hope to see the next steps and support the implementation. Muchísimas gracias a todos. Estamos aquí para ayudarles, para contribuirlos y para aprender. See you next time, next month in the speaker series. Bye bye.
Thank you very much.
Hasta
Muchas
luego.
gracias.
Bye.
Gusto verlos.
Yeah.
Gracias.